So I welcome to Medicine Grand Rounds to everybody that is on. I have the real pleasure of introducing a friend of mine, a mentor, and a role model, Dr. Carlos Suzada, who is the vice chair of the Department of Infectious Disease at the Cleveland Clinic. He did his medical training at SUNY Buffalo, and then has been a Cleveland Clinic man since then, doing residency, chief residency, his fellowship, and subsequently on staff and faculty at the Cleveland Clinic since then. I met him when he was serving as program director of the Fellowship in Infectious Disease there, which he did for 25 years, from 1994 to 2019. And in addition to that, he served 3 terms as associate program director of the medicine residency program, spanning about 13 years over those times. In the last of those, he was the director of the curriculum for medicine residency. Dr. Isada is honestly the most innovative educator that I've ever met. And if you look through the kinds of innovations and the different curricular changes that he brought forward into the Cleveland Clinic program, both at the fellowship level and at the residency level, often studied, showing improved learning and training in the learners, the fellows and residents, with published literature. But and these have included things like developing more than 200 PBL cases that became e-modules with really probing questions to understand the clinical reasoning and the different types of literature that supported clinical reasoning and management. But simulation innovations, conference innovations. He developed a Y-week curriculum, which is something we're struggling with now, Carlos, with a pretty new X+Y system that showed measurable improvements in resident medical knowledge. I could go on and on about his different accomplishments clinically in medical education, but also clinically, he's a phenomenal clinician with a special interest in neuroinfectious disease, and also holds appointments in the Department of Pathology and Laboratory Medicine and the section of neurologic infectious disease at Cleveland Clinic. So I am thrilled to introduce really my friend, my former colleague, and again, a true role model for me as an educator, Dr. Isada. And he will talk to us about how doctors learn 10 innovations in medical education. So Carlos, I will turn it to you.
And just give me 1 second here. Is
Sure.
this visible to folks?
Visible, but not yet in presentation mode.
Not quite. Okay.
And that is in, yeah. Perfect. That looks fantastic.
Well, thank you, Dr. Armstrong, and it really is my privilege to give this address to a very fine institution here. And I wanted to go over a few things that I think I've learned over time, and hopefully, in all humility, I'm trying to go over 10 innovations in medical education, but I would say maybe a fair number of these were more successful than others, and perhaps some of the things that I learned over time. No financial conflicts of interest. And so I'm going to do a little bit of an outline. There's an introduction, a little bit about the training environment here in Cleveland, 10 innovations, which in some ways I might consider interventions rather than innovations. We'll go over a little bit about problem-based learning, some curriculum design, evaluation, some of the main components of medical education, and probably finish up close to conferences that don't work. Maybe one unknown medical case to go over briefly, and then perhaps briefly some thoughts for the future. And my hope is that maybe we can collaborate with some educational related projects in the very near future. So when I first took over the fellowship in ID in 1994, I was I didn't have a lot of background in some of the medical education theory, which I actually acquired later over time through an MED program. But I was very struck by this book from the National Academies of Press called How People Learn. This actually was later a part 2. So these are very, very good books, which I will summarize a little bit here. So some of the principles of how adults learn. Students come with numerous preconceptions. To gain proficiency, adults must learn to accumulate very deep factual knowledge. Active learning is greater than passive. Multiple passes through the same material are mandatory. We also have to do frequent assessments, which are mandatory. Learner self-directs, and then this concept of metacognition, meaning that a learner should be able to step back, look at themselves almost from above, and then see what's wrong. So that's a very difficult thing to accomplish, but I think that's one of these principles that have been pointed out for actually some years. So here's the ideal learning curve, so that here's our increasing performance. This is increasing amount of deliberate practice. Here's maybe the y-intercept where we maybe have our initial performance level, and then there's a slope or rate of learning. And then theoretically, there's this inflection point where the learning becomes more effortless. And then we go up to a sort of an upper asymptotic area where you have maximal performance. And how this is translated into medical education, and many of you have seen this, where we're a novice, then we go to advanced, competent, proficient, meaning we could do these on our own, but probably not the greatest supervisors. Expert, we can do it. We can also teach others. And then there's this concept of automatic expert, where we are, maybe you're 20, 30, 40 years in your career, and you're kind of on autopilot here, and then you flatten out a little bit, as opposed to this new concept of the deliberate expert, where we keep pushing ourselves to get better, and then this goes. But I should say this is idealized, because in fact, here we do not go to infinity. And as many of you know, that there are some studies that actually it goes down somewhat over time, but I choose to truncate it there, just for my own peace of mind. So the training environment at the Cleveland Clinic, we're a tertiary center. We've got 1,100 beds at a main campus in Cleveland. We have a lot of regional hospitals where there's trainees, and if we add all our trainees together, we're about 2,600, and a lot of them rotate around here. I've been privileged to be the fellowship director there, 1994 to 2019. For our fellowship design, we've had generally 3 fellows per year over 2 to 3 years. We've gone anywhere from 6 fellows in total at any one time to 9. Our faculty has had actually a big explosion over the years. We used to be 6, and now at my last count, we were 32. So this has really been an expansion. Our fellowship is a clinically oriented one that may have bearing on some things that might be interesting to your program, but we still have a fair amount of research. Some do more than others. So maybe about 25, 30% where there's a serious research expectation. We also have a little bit of a unique design in our ID department, where there are general consults, but there are also a number of subspecialty ID services, such as transplant, endocarditis. I do the neuro, and there's others. I'm also been involved with the internal medicine residency program even longer. So I've been in and out of the IMRP as the associate program director. So I've been doing various stints off and on for maybe 4 or 5 years, actually from 1992 up to last year. So I sort of wear 2 hats, do both fellowship and the IMRP. I'll speak a little bit more about the fellowship here, but we'll make some comments about the residence because it's a big residency program. So this is our class of 2024, and it never was always this big. I mean, we have 55 categoricals, and then you add on, I think that's like 15 preliminaries. So it's completely different from our fellowship. So a big contrast. And I've learned a lot of lessons about what works with a big group, what works with a smaller group. So the first, I would say, innovation was something called problem-based learning, which was a curriculum we put at the fellowship level. And one of the questions underlying this is, how do we make this core curriculum, which is the basis of our academics, more effective? And so what we had, the essence of our problem was that we had an old curriculum. So when I picked up this fellowship in the early 90s, we used to do something called a Mandel review, and that's based on the Mandel's classic textbook of infectious disease. We would meet maybe 1 to 2 hours per week, mainly fellow prepared, so they would sort of slog through the chapters and then summarize them, and then we'd mix them with more traditional didactics from our staff. Well, as you can imagine, there are a lot of drawbacks, although this was the standard at the time. I actually didn't know any better, but I noticed that how non-interactive it was. We very rarely touched on any classic articles or the primary literature. We had, as there's always a problem with didactics, lots of problems with scheduling, cancellations, and there was actually a limited number of prepared talks from our faculty. So we were always very limited that way. And despite over 100 hours devoted to this one conference alone over the year, I still wasn't sure how much they knew. And it seemed that everybody was disappointed in the level of the medical knowledge, including the fellows. And in formal feedback sessions, they ranked it as fair, which put it pretty low on our hierarchy of which conferences work. I tried to improve this with some pre and post testing, after each of these, but that did not work. So we made a little bit of leap here to do a Pbl based curriculum. I started this as a pilot around 2000. Now, I didn't know Pbl, so I was in a generation where I knew what it was, but I'd never experienced it myself. Many of our fellows, though, had been actually quite schooled and grown up with PBLs in medical school. But when we looked at this, there was really essentially nothing in the literature about PBLs at a GME level for residents and fellows. So I was very worried about this. Now, would this even work? It works for med students, but this is a completely different training environment for a fellow versus a MS1 med student. So just as a review, a little bit of the Pbl principles. One is that a problem is presented to the learner without necessarily having any formal teaching relevant to solve it. The student is the center. They have to go out and get the data and synthesize it, small groups you're familiar with. And the study is directed by the specific clinical problem. You're supposed to identify, we call them LOs or learning objectives, which are the knowledge deficiencies. And then one of the interesting thing was with us as teachers or facilitators, we just keep people on time, basically. So you might ask a few questions, but you are not the content expert. Now, there's, without going into this, there is a large body of evidence in the medical literature supporting that this works. But this was mainly at the med student level, but this is a tremendous number of articles looking at this. And it was consistent with these principles of adult learning theory, many of which we just went over. So in our new curriculum, we switched this basically to many more PBLs than didactic lectures, although we didn't completely get rid of the didactic lectures. So over time, we found about 60 PBLs cases per year. We tried to group these into blocks, learning blocks. So for example, it would be a block of neurologic infection PBLs, GI, and so forth, each of them going about a couple of months. But we didn't completely give up the didactics. In fact, we usually led out the section with a couple of didactics on GI infections and then had PBLs afterwards. Most of these came from PowerPoint cases that we collected from our weekly case conferences, and some were from the literature. So here's at the top is an example of one. This is actually the full PBL on one of ours. So we presented these mainly as diagnostic unknowns. We did do some other formats, including management dilemmas, so they weren't always, differential diagnoses. We had about 70% of these were our cases, which quite frankly, it took us about 5 years to build up a critical mass of cases to make this happen. They're short, sort of like these cases up here. There's not many, but they were quite difficult. And we tried to choose cases that were not likely to be solved by pattern recognition. We tried to include a lot of CTs, MRIs. We didn't put the interpretations in, so a little skill in trying to interpret nodules or strokes, that type of thing. Our basic philosophy was we're going to try and use cases that were more or less right down the middle, so not incredibly obscure, but we also wanted to put in some curveballs. into this group, meaning that, for example, if we were in a section of pulmonary infections, we would include an acute sarcoid or even a lung cancer, things that would mimic ID, so the fellows weren't always key offing that this was an infectious etiology. We also wanted to be sure that we included some unusual, atypical manifestations of a common disease and really tried to stay away from a lot of zebras. We didn't really like going into the literature to find case reports. I actually found that quite difficult because most of those were quite obscure and exotic, which is why they're case reports. So those didn't go over very well. We also felt this fit in well with the ACGME competencies. So there was frequent and systemic assessment of medical knowledge. It fit the 6 different competencies. Lots of interaction, pretty enthusiastic, that lasts for a long time. The peers actually did a lot of teaching. And when we gave cases again, we were impressed by how well they did on similar cases. And then we were able to shorten that didactic portion of things and replace it more with PBLs. But not everything was completely rosy, so in addition to taking a large amount of time, there was this one thing that I hadn't even realized when we do it this style. I called it the one case, one problem model. For example, of course, in ID, group-based strep is an important pathogen here. So for the topic of group-based strep, ideally, one would find and compare a case of group A strep necrotizing fasciitis, group A strep sore throat, rheumatic fever in a traveler, erysipelas, post-strep GN. So you would need actually 5 cases to cover group A strep. And there's just not enough time for all that. So how should we struggle with that? Should you use just one illustrative case of group A strep, maybe pick one of those, and then just didactically cover the rest? Sometimes we did that, but in some ways, philosophically, this defeats some of the purpose of PBL in the first place. So eventually, and this is actually my office. So we had a huge amount of PBL materials that just got out of control. So, I was a little more old fashioned then, but we found a online learning management system. We happen to use Moodle, but there are others. And we used it because it was quite popular and was free. And we did present some of these. Once we established what we thought was pretty close to a full Pbl based curriculum, we presented this more as a work in progress at several different national meetings. Each time we made some advancements, we would present that, and actually got quite a bit of feedback, but also a number of very salient and important questions to us that moved us to the next level, which is our sort of innovation 2, scoring system for PBLs. So one of the things that some of the audience at these meetings said, well, what are you going to do with these? Okay, now you're saying how great it is, but can you actually use it to quantify diagnostic accuracy or some kind of cognitive error? What are we doing with these results? So one of the fundamental problems is, these coming from the ACGME, we in training programs are required to both quantify and measure multiple areas of clinical competence. And these metrics should demonstrate quantifiable improvement in most trainees over time. And I was really stunned by this. Like, how are we going to do this? It's just a particularly difficult task for complex behaviors such as diagnostic reasoning. So we, by this time, had established a protocol for our PBLs, and we're hoping we might adapt it to that. We had gone to this online Moodle system we talked about. So our protocol was that the fellows would take maybe 30 minutes per case. We didn't want them work on this for hours, but they were open book. They had to work apart. They had to be open book. And we figured this was actually simulating a typical patient encounter. You don't have, oodles of time to see these patients. They're all lining up in your clinic here. So you have to move a little bit fast. We also asked them to submit their answers into a standard format, which would be about the length and simulation of a patient chart note. So they'd essentially be writing their assessment and plan part and just skipping all the rest of it. And for each case, we asked the fellow to list a few things. One, their top 3 differential diagnoses. Then they had to list a little bit about the pros and cons of each diagnosis. And then we forced them to pick their number one diagnosis. So that was the format which we wanted them to submit their answers in. And this is a screenshot from Moodle. So basically, one of the first questions actually I like is what is the anatomic considerations? But then we basically had differential diagnosis 1, differential diagnosis 2, your list of pros and cons. We actually asked at one point about confidence level, differential diagnosis 3, pros and cons. And then we forced them to commit to giving the number one diagnosis in some ways, much like the New England Journal CPCs, where the discussant is forced to give one diagnosis and actually pick all the rest. So we divided this fairly simple grading system. And, if there's time, I'd be interested in people's thoughts, but we said at grade 1, the actual diagnosis of the case matches the fellow's top diagnosis. So number 1 equals the 2 diagnoses. We call them grade 2 if the actual diagnosis is one of their top 3. We limit them to 3, so they're close enough, they're in the top 3, and grade 3 was a miss. Their diagnosis was not even the top 3. So this was how we tried to make a simple diagnosis and grade these. So one of our pilot studies on this, they did about 120 cases over 2 years. We had 17 fellows when we first looked at this. And interestingly, as a group, these year 2 fellows had actually significantly more grade 1, that's the good one, and 2 responses versus the first year fellows. I'll show that in a second. And then when you compare them year over year, the number of diagnostic errors, which the grade 3 was an error, for any individual fellow actually significantly decreased. And so here is a quick summary. So here, the grade 1, that means your number 1 is the number 1. Grade 3, you're 0 for 3. These are the year 1s. These are the percentage correct. So basically, if you look at the year 1s, they have a few grade 1s, so they're on the money a few times, but then grade 3, they have a large number of errors. And it's a little bit over the map with the second years, but by the end of the second year, their grade 3 errors were significantly lower than the errors of the first years. So we were encouraged by the fact that we could almost passively collect this data because I didn't have to score the PBLs. In fact, they're self-scoring. The fellow knows if they're in the top 3 or not. So I actually never had to ask them, how did you do? They told me. And so this went into something we call a hybrid rotation or the crash course. This is from the AC Jimmy resident survey that I think a lot of you are familiar with. So at that time, one of the questions was, do your rotations and other major assignments emphasize clinical education over any other concern, such as filling service obligations? So this has been a question that has plagued me for 20 years. How do you know what that balance is between clinical education and service? And the other one that really bothered me as a program director is this question: what is the ideal ratio of related didactic time to clinical time? And I'm embarrassed to say this, but I heard an abstract at one educational conference years ago that someone presented as an abstract, and they did a nice study where they said that if you had a setup where you had, say, a 4-week cardiology rotation, one of the weeks was completely didactics, 3 of the weeks was a standard rotations, and you compared that with the usual 4 clinical rotations, the people who were on the one didactic to 3 clinical actually do better on clinical than those who were on 4 weeks of clinical. Unfortunately, that was never published, so I could never reference it. But it's one of these things that you just hear in your life and you say, you know what, I think that's correct, even though the data is limited. So that was this. They did seem to do better in clinical performance, even though they were doing less clinical weeks. So we tried to integrate some of this concept. So again, we had a different moving parts here. So there were the PBLs. We are actually in our program have a little bit of lab in the patients, which we think the patients are the key to the curriculum. So we developed this thing we call subspecialty learning blocks. So I'll give you one example. Some of the fellows do a hematology, bone marrow transplant, or BMT block. This is usually 8 weeks. So this started out as week 1. They go into this course. It's an intensive course. I'll take about a second, where there's classroom work and stuff on Moodle. Then weeks 2 and 4, they actually go on service. So they do 2 to 4 weeks of heme BMT clinical. Then they're out again in week 5. They do part 2 of an intensive course, but this is mainly in the microbiology lab, in the mycology lab. Then they go back to the heme BMT for more clinical work. So this is what I'm talking about as a hybrid course between many different experiences. And what it might look like is this, that you have, you start off with the course, and ideally this didn't always happen in the beginning. You do heme BMT, so clinical work, and then maybe some general concepts to mix it up. Then you're back on heme BMT and then another course. So it was really sort of this hybrid design. Now, what are these crash courses, we call it? Well, that one crash course in week 1, it's usually 5 days. Self-study for the most part, but there were very specific readings. We had webcasts they watched. But one of the key things is we asked them over all that 5 days, is to put together 2 talks on their own. These are their capstone projects. They could give 2 PowerPoint talks related to the subject. So, for example, they might do infections in neutropenic hosts, infections in BMT, and other mold infections. And then they would give an antibiotic talk on antifungal, since this is so key for this rotation. And the second week, the week 2 of the course, that's this one down here, they're in the lab. They have a few recordings, a few assignment readings, but this is mainly lab work at this point. So at the end of the full block, we asked them to actually show competence. So they would have to give these lectures. There were 2 lectures with feedback. They had to give in their Pbl cases, the worksheets. And then if they presented a case conference, which they're supposed to, they had to give their PowerPoints, and then they had to submit to a portfolio in order to answer this question about the balance between academics and service. So that leads to this idea, number 5, of structured portfolios. And as you can imagine, there's lots of moving parts. So we have many, many different things coming from a lot of directions. And I just personally administratively couldn't handle all the different pieces. So here's an example again from the heme BMT. So specifically for what we just went over, that would include their MedHub evaluations from faculty, the standard ones. But they had to keep case logs, including the diagnoses, and we asked for them on a spreadsheet. They had to turn in their PBLs on Moodle. They had to actually have given these didactic talks, usually to the residents, so the febrile neutropenia, whatever they chose, antifungals, any case presentations they made. And then since they were a week in the lab, we gave them a mycology lab quiz, and then whatever else they had, additional fellow work. And I just give you a little bit here. This is an actual portfolio that one of our fellows gave. This was back in 2015. And it's 6 months, right? So this is their CCC, Clinical Competency Committee meeting at 6. And we have the fellows actually present to the group. And I'll just give you some highlights of it. So basically, we've asked them to give numbers. How many are they doing now? So she's seeing 60 HIV patients. What did you do during the 1 week of the 6? So you're 20 and 3. And then they give some of these. And she also did an afternoon at our sister hospital where they did gynecologic HIV. So a little bit of diversity here. Then the same thing for what we call granuloma clinic, another outpatient. But what I'm showing you here is that they actually did do these things. So we gave them their tending, the gender of the patients. There are no clinic numbers, but we gave them the diagnosis. So we got a pretty good sense of what they were seeing and what they were missing. And then they wrote notes regarding each of the patients that might be used later. Same thing for hepatitis clinics. So they actually were very good about keeping patient lists. And for other activities that are not patient related, during that block, they had an infection control week. So she could complete the SHE online certification course during the week and actually did an outbreak investigation session with a chair of our department at the time, got a certificate here. So I thought a rich experience mixed in with these learning blocks. And one of the things when we asked them to go over their this is for solid organ transplant, we asked them to include things that the staff put in as comments. So here, this is a verbatim from Dr. XXX Teachable. This one overall good thing. And then she made these comments about areas that needed improvement. So we were trying to pin the staff to do these things, put more than just check boxes here. And one last thing is that from our general service, we call it the B list. One of the things we asked them to do is actually to find not so much errors, because it has such a connotation, but we wanted to have them find what we call 3 discrepancy in management. So the fellow had to find discrepancy between what they thought was going on and what the staff thought was going on. And then they had a chance to discuss these during their portfolio review. And then a long list of presentations, which is actually amazing, over 6 months. There's only 6 months of their presentations. And then she discussed her research, the MDRO colonization, and the second thing with hand hygiene, which she presented at our national meeting. And we asked them to give feedback about their own learning program. Think about my endpoints earlier, areas where I need more exposure. She thought that she needed more radiology, immunology, et cetera. And then we asked them to talk about us, feedback to our program. She was happy that we set up this one rotation called Granuloma Week, but also said, we got to work on our attendance for the faculty. She was actually concerned that she was doing less patient care and a lot of this, almost too much of this learning time, and thought we had balanced it the opposite way. And that we had sort of dumped the research conference and had to revive that. So one of the other things is what to do about lab projects. So can you incorporate basic science into a clinical program? So this has always been a big challenge. Just very briefly, one of the problems is that there's almost never basic science discussions in a typical free-form case, discussion of a clinical case. So in meta-analyses, this problem of no discussions of basic science has been pointed out as one of the weak links in PBL methodology based on meta-analyses. So what we did was to try and include some lab-based PBLs into the didactics. And one of the things is our fellows do rotate for a month in the microbiology lab, and we sign them unknowns. So when they first start, we give them 12 unknown test tubes. We tell them that there's something in there and they've got a month to figure out what it is. So they have to identify each organism by first principle. So I'm just going to show you one example here. This is our R2, that's our second unknown. So the fellow has to figure this out from a gram stain, how it looks as hemolysis on the plate. There's dimpling here. Then they have to figure out which ones to do, very hands-on. And then he identified this as strep pneumonia based on this bowel solubility and something on the microtiter play. And they give good proof. So it's very interesting that they show this bowel solubility to prove that their conclusions are accurate. Another one where he wound up with something called the Esbl, or highly resistant E. coli, after he went through all the hand chemistries, and then went to show us very nicely some other more sophisticated tests to show how he had figured out about using quality controls and indel positives. So they're doing this on their own. Very, very impressive, and a lot of work to try and identify this. And this is separate from the work that they and the curriculum that they have through the microlab. They're doing these all on their own. So number 7 is something we call the mentor model, which I'm very proud of. And I taking Coles to Newcastle. I mean, your Emory is very, very well known for this. And I just want to show you a little bit of the spin we had on this for such a wonderful place as your own. So again, this is almost goes without saying. It's very, very important. Overwhelming body of literature supports that there's benefits of having a mentor in medicine. A couple some minor limitations. Mostly this is research mentorship in the literature. It's usually med students and only a little bit about residents. And it's usually surgical residents and not so much medicine. And we actually know less about the benefits of clinical mentoring. Most of this is research related. And in some of the programs, there's quite a bit of data supporting that Not all programs have a mentorship, and even in those programs where there is a mentor, there's a fair chunk who actually don't have a mentor. And one of the other issues are there other objective outcomes other than sort of trainee satisfaction surveys? So I just want to show you this briefly, that in fact, mentoring can potentially help burnout. So this was a cross-sectional survey that was done recently, where they looked at various instruments here, like a coping scale, life event scale, and they correlated these with the residents here, an emotional exhaustion scale, cynicism, and the Maslow burnout scale. They actually did this over a fair number of residents, 616, and there was a really strong negative correlation between mentorship and emotional exhaustion. So one of the many conclusions of the study was that mentoring may be protective for IM resident burnout, and you could show this objectively. Other studies have looked at how to just increase the number of mentors. In this one interesting study, they set up a new mentoring program in an IM residency, and they sort of did a mix and match with bio sketches between the faculty and the PGY2s. The residents contacted them, and 96% of the residents actually identified a mentor through the system, whether they were old ones of theirs or they were new, compared to only 50% before the intervention. And with these, nearly all residents described that their mentors were invested. So the conclusions were this sort of facilitated selection using the system of formal mentors produced relationships that were actually similar to the pre-existing ones. And so this model may increase the prevalence of mentorship without actually decreasing any of the quality. So I found that very encouraging. So we approach this in a little bit of a different angle, and more of a clinical mentorship, and whether these may actually solve several additional problems. And these may seem unrelated, but I'll come back to these, because one of the banes of my existence is the MedHub evaluations. So there's missing and delinquent MedHub trainee evaluation forms where we are 40%. So this is generally where we've been. And with a lot of reminders, i.e. nagging, we can get up to 70%. But I'll tell you, I was working here where we didn't have MedHub and it was written, and we'd be somewhere close to 10 to 27. So we also know that these are checkboxed a lot. So there's no comments. The other problem we found, sort of unrelated, is that fellows rarely see hospital patients again. They do the consult in the hospital, but then they never see them again unless it's by accident. And of course, what happens is they're limited with their understanding of the long-term course of disease, since they're not seeing them again. And this is from the ACGME. They say assignments of rotations must be structured to minimize the frequency of rotational transitions. They have to be of sufficient length for quality education. You have to have continuity of patient care and longitudinal relationships with faculty members and meaningful assessment and feedback. So all of these things are very challenging, I think, for all of us. So I had this idea that we would try something based on the old surgical training model. Now, of course, they don't do this anymore, but this is what they were doing at the time. And this was an interesting model I was fascinated with, that in the final year of training, so what, PGY 4 or 5, the chief surgical resident would traditionally operated with one surgeon for 2 or 3 months at a time. They do everything together, much more of an apprentice model, but then they switch. So one general for 3 months, maybe a colorectal, maybe so, but they go through the rounds and they really get to know how to operate with them and how to take the outpatients, phone calls, that type of thing. So I based this on that, where we did more of an intervention than I considered an innovation. And it was similar. So the fellows would rotate with their ID staff for maybe 2 to 3 months at a time. And the beauty was that they both worked off the same schedule. Both the inpatient and the outpatient were the same schedule. And the fellow rotation scheduling is really easy. They actually didn't have one. We're obligated as faculty to see many of our hospital consults in the clinic, but of course at that time the fellows weren't. And we're supposed to follow them as an outpatient PRN. So in this system, since we're all working off the same schedule, the fellow automatically sees almost all of the mentors outpatient. So whoever you scheduled you from the hospital, you would probably see as an outpatient, including what I considered highly valuable, those hospital discharges in the transition of care. They still kept their panel too, so they did a little bit extra here. So it would look something like this. Again, this is a shared schedule for the fellow and the staff. So they might do clinic together, then they go into inpatient, the general ID together. Maybe one of them's on vacation, the other one's doing research if they're out. And then they would have a stretch of clinic, research, PBLs, other things. And then they would go back on the service, inpatient, but maybe it was a subspecialty, maybe a little bit lighter. So some of the benefits, we got 100% of MedHub returns, 100%, no reminders. And the comments were very detailed. Staff were very happy. They felt more confident. They could see them develop. Actually, the oral feedback then naturally occurred, and it was sometimes even more than once in a block. Again, our individual staff had a couple of areas of these subspecialty interests, like bone and joint infection, neuro, like me. And so the fellows would be in this typical mentor block. They would have usually a month of that, 4 weeks, in addition to their outpatient or inpatient work. And they would see these subspecialties in both inpatient and outpatient setting. And they would attend some of these meetings. So they're, depending on the rotation, you might go on monthly disciplinary transplant rounds. You could, if you're on endocarditis, echo and valve rounds, which you probably wouldn't go to normally. With me, we go to RADS rounds, every other day. If you were with one of the infection control people, you would attend the infection prevention meetings with the nurses and others. So there was really a very rich experience that actually I hadn't expected. And we did a short study to see, did they actually see more hospital discharges? And just briefly, here's the traditional model. And then here's our mentor model. And there's individual fellows. These are the number of follow-up visits. So fellow 1, fellow 2, 3, 4. And here are the mean number of patients. And just basically, they went from 5.5 hospital discharges that they saw with a 2.1 SD to 10. So they essentially doubled the number of transitional patients from the inpatient to the outpatient. This evolved. And I'll tell you, this actually wasn't particularly popular when I first brought this up. And they said, you want us to be with 12 weeks together? What if we don't get along? Is this really a good idea? So we cut it to 6 to 8 weeks. Turned out that there was probably more outpatient weeks than I really wanted. Sometimes these were slow. The fellows were happy, but not happy. So they also wanted to work with more staff and thought we were still limiting them too much. So I made a few missteps on this, particularly random pairings. I really kind of ignored which staff went with which fellow, particularly for the first ones. And so later we wound up limiting the mentors, at least for the first years, to senior staff, meaning those who've been around for 10 years or people who were part of the CCC. So now the model is year 1 fellows, we pick it for them. So we pick them because they don't know. We put them in the mentor model for 3 months or for 9 months, and about 3 of those are research mentor. Year 2, they can do whatever they want. They could either do the usual 1 to 2 rotations, or they can go into a mentor model for part of that. One caveat is I don't think this mentor model would work very well in many different environments. So, but I thought this was an interesting variation of things. So just one thing about getting those MedHub evals, you have to be careful because in this one study, this was in an emergency medicine residency, they implemented an education dashboard in 2017, and they asked the questions, do financial incentives, i.e. money, you give the faculty money, will they complete more MedHub evals, and would they show up to conference more? And they made the point that these types of incentives are around in business, and they're increasingly more used in healthcare. Now, to get this money, you had to do 100% of MedHub evals, and you had to go to at least 25% of the didactic conferences, which translated to about $1,000 per quarter, which was about 2% of the ER doc's salary. It was a pre and post observational design, not a lot, but there were 17 attendings. And I found this interesting. Your Med Hub completion rate, which was kind of like our 70, went skyrocketed to 100%. The conference attendance didn't change at all. So there's somewhere around 40%. And again, one more caveat, does quantity of the evals equal quality? Without going through all this, they sent a lot of surveys to different residents, did a R2 Pearson correlation coefficient. And actually the mean number of evaluations for a resident were 39 over this academic year of one. And there was absolutely no correlation between the number of evaluations a resident or fellow received and their satisfaction with feedback. They actually did not regard the evals as feedback. So the author said, faculty summative evaluation is very important, but this appears to miss the mark. It's not a replacement for ongoing data-driven structural resident feedback. And understanding the difference between evaluations and feedback is a global concept important for all of us, the students as well as the learners. So coming to the end here. On the flip side here, evaluating the faculty, is it confidential? Some of the faculty evaluations. So here is question 7 from the ACGME survey, which really bothered me for some years. Do you have the opportunity to confidentially evaluate your faculty in writing at least once a year? So the problem that I found is that some trainees do not believe their evaluations of faculty are confidential. And their concerns have been raised at multiple levels of trainees. Since they have to log in with a username, it's not confidential. You can track these evals back to me in a nanosecond if you really want to. That's the concern. And this is a second problem in smaller programs like ours. The concern is that faculty may be able to identify a trainee by the type of comments, and particularly when it's negative feedback given, they can figure out maybe who this is. And so each year, one of our fellows would answer no to that ACGME question. They can't give them confidentially. And it drove me crazy. Like, why can't I get this to be 100%? So I tried to address this several ways. Okay, so we had our Cleveland Clinic GME meet with our fellows, assure them they're confidential. That didn't work. I even got a lock box and say, okay, you can type it in with gloved fingers and put it in. That didn't work. Closed meetings with the chief fellow. Then we actually did something called the no-fly zone list, where confidentially each fellow gave to our administrator people they absolutely couldn't work with. So I said, fine. And I never saw these. Unfortunately, there was nothing in the literature to guide us on this. It got to be a little bit better over time. You know, maybe it was these things. I don't know. But I still had this lingering feeling that the faculty evaluations were not 100% honest. So I had this idea that maybe we try something completely different. Let's make the second year of training completely elective, but not just elective in terms of the rotations, but the specific faculty supervisor in each rotation. We'd never done this before. You choose a rotation and you choose a supervisor. Now, you might consider this somewhat Darwinian, with the idea that poor teachers would be weeded out over time by natural selection. And the concept here was, okay, the best teachers would be rewarded. You get lots of fellows. The worst ones would actually be congregated into this sort of non-teaching service by default. And thankfully, I wouldn't have to actually do this. And it worked. This was really easy to do because the faculty eval came out a couple of weeks before the fellows were due. So this is extremely easy to implement. The fellows had weeks to figure this out. And I actually thought this would probably be a much more valid measure of teaching effectiveness than the Likert score. Now, about 6 months into this, I got called on the carpet by our Cleveland Clinic GME. They were not entirely happy with me on this one and said, all right, this is fine, but you realize trainees will only pick faculty who like them, and they will automatically get them good grades. And it actually was something I hadn't thought about. So here are our surprise findings once we put in this mentor model. To my surprise, the fellows did not cluster around the teachers with the highest teaching scores, including me, to my chagrin, but they were equally distributed amongst essentially all the faculty. Now, certain fellows avoided certain faculty. I thought that was just human nature, but all faculty had nearly the same amount of contact time. It's almost evenly divided. And the faculty who were the toughest graders and had that rep actually were a little bit more popular than the rest of us. So in retrospect, I thought this was probably an issue of miscasting. And under the right circumstances, even those faculty with the least interest in teaching, usually they're more interested in research, could perform, I would say, brilliantly, very effectively in the right setting. I just put this in for miscasting. This was John Wayne as Genghis Khan. So anyway, last one. So Journal Club, the bane of my existence. Do your faculty members regularly participate in Journal Club? It's necessary, but, and I think we all agree on that, but it's difficult to do effectively. There are over 2,000 publications on medical journal clubs alone. What we know, if you go back in the 1980s, there's several studies which found that critical appraisal skills of physicians were poor. Practicing clinicians, so some of us older guys, understood analysis and could interpret the results in only 21% of articles. Now, what about our residents? Clearly, they're young, they're out of training. How are they going to do? Well, this is an often quoted study from Yale back in 2007, where they did a cross-sectional study of IM residents in that area. They looked at 11 programs, a fair number of residents here. And basically, they asked them 16 questions as part of a validated instrument, basically on biostats and study design. And they based these choices of questions on commonly represented stat designs in contemporary studies. So I just give you one example here. So just bear with me and we'll give you a little quiz on this one. So anyway, to determine if fasting is associated with dengue fever, data from 40 patients with dengue fever were collected. These patients were matched for age, sex, and race to 40 patients without dengue fever. Hospital charts of these patients were then reviewed to determine whether they also fasted prior to their illness. This type of study is known as cross-sectional, concurrent cohort, case control, and retrospective cohort study, or an RCT. And the answer is a case control study, which I thought was a fair question. But interestingly, only 39% of the residents answered this one correctly. And these are seniors, by the way. So overall, this was actually not that unusual question. They got about 41% correct. And if you looked at faculty with some research training, it was about 71%. The residents had really a hard time with Kaplan-Meier interpretation. So that was only 11% correct. And something I thought was surprising, even trying to figure out confidence intervals and interpreting them, 11.9% correct. 75% of the residents felt they did not understand most of the stats they encountered in journals, but 95% felt it was important to understand these. And the author said most residents lacked the knowledge and biostats needed to interpret many of the results in published clinical research. And to us, this was a vexing problem. Our journal club was spotty attendance. They were often disengaged. We had scathing negative feedback to us as course directors of this. So we tried multiple best practices. And in fact, I quote one of the, I referenced one of the best practice guidelines. So we tried case-based journal club, where we bring a case into the journal club to begin with, small group seminars, large group seminars, team-based learning. Nothing really worked well. And the other thing that I noticed for years, was one of the fundamental problems of this is that most residents did not read the article in advance. And I found it was about 10 to 20% read the article, even when we went to the X plus Y system, where when they were at journal club, they had really no other clinical duties. And the reason I got this number is I just would ask the group. So the group is maybe 15. I say, who read it? One person would answer their hand, maybe two. That was it. They were very honest. The rest of them just said, we did not read it. So I developed this reverse journal club format. And in this one, it's quite different. So we actually keep the article a secret. So it's deliberately hidden from the audience. The resident still prepares the same presentation as you might do for a traditional, maybe like a half-hour journal club session. And then you meet with me as a faculty, sometimes for hours beforehand. We make a plan. So at the start of the J Club, for the first 10 minutes, the resident presents to the audience background medical information and actually specifically frames the research question we're going to try and answer, following essentially the introduction of the article. Then he stops. From then on, the audience pretends they're the principal investigators and designs the study from scratch. And at the next 30 minutes, the faculty, usually that's me, facilitates this audience discussion. So this is me here. Here's our group. We pin them on questions. What is the best study design to answer this question? Is it case control? Is it, is it cohort? What is the best one and practically? Then we pin on things like definitions. What are your case studies? Who is the population? Who are you including, excluding? Primary outcome, sample size. What stats should you use? What should we code for in table 1? And then the one I like is, what should the main results table look like? You should be able to draw the results table and then fill it in later with the results. Then we pass out the article. So once we 30 minutes, we give to the audience. And then the next 20 minutes, the resident reviews the study methods that the authors actually did. He compares it to what we did as an audience, summarizes the results, and does his critical appraisal. We try and rotate the study design. So every 6 months, we try and do randomized trials, cohorts, case controls. I thought this was very positive. The audience was engaged. The residents were better able to understand the study design. The downside is most faculty are not comfortable running this in the style. So pretty much I do almost all of these. There's just some residents still do not participate. And finally, the future. I've been very interested in both simulation and virtual reality. And years ago, I was involved with this program called Decision Sim, where you can use these branch points where you start off with a case and then make different nodes and make a simulation of a variety of different clinical problems, and carry that to a certain degree where we actually did this for a curriculum in microbiology, where we were able to use that decision sim to help the fellows learn how to do microbiology. So it was, and here's our decision map, node map. And it worked fairly well, but it was just a huge amount of work. And I've been very interested finally in virtual reality. And there's clearly evidence that VR can play a major role in clinical simulation, not just procedural simulations. Right now, most of VR is in procedural simulations. There's ongoing work of this at Cleveland Clinic, particularly in our med school, where they actually use HoloLens, Microsoft, as part of anatomy. No cadavers. It's all, this is already there. I'm looking to try and replace my tried and true PBLs with at least a VR component. And finally, I would love to collaborate with many wonderful sort of forward-looking groups, hopefully like yourselves, with large progressive institutions once we've worked on some of the kinks of the VR system. So in conclusion, I gave you hopefully not so much 10 innovations, but I'm hoping 10 ideas. I'm hoping that maybe some of these might be useful to you in the future and maybe pique your fancy for collaborative work. I think that's one of the biggest deficits of medical education research, is that they're all single center. So many could be with a big enough end and some good collaboration, really do some good work over the next years. So I wanted to thank Dr. Armstrong, the organizers of this grand rounds, and I hope this has been of use to you. Thank you.
Thanks so much, Carlos. That's wonderful. One of our ID faculty is suggesting he may reapply to ID fellowship with you in the future here. And you may want to take a peek at a couple of the comments. we are at time. I'm going to just quickly ask you one question, although I recognize we may lose the audience. But the question is, how do you, this requires really a lot of faculty engagement, not just you. And how do you, incentivize support, either salary support for education or for faculty volunteers? How do you incentivize engagement from other faculty?
That's an excellent question, of which I still struggle. I think it's actually been less of a problem that I thought. These days, for example, I'm not the program director anymore. So our own program director still has their 20%. The issue is more for the key clinical faculty. But I think because it dovetails so well into their clinical activities, that it takes less time and it's more of a focused activity that they do with a fellow. And it's almost something that they would normally do. For example, one of the faculty maybe was miscast at being a mentor in, say, an HIV clinic. Now, that didn't go over very well, but when you put that individual into a research mentor position, they absolutely are amazing and they'll do it for free. So we found that just the fact that they're motivated, the fellow actually does accelerate the note writing for the staff. And I think there's those benefits too. Plus the fact in the mentor model, the fellow actually helps the staff quite a bit and frees them up with time because they're working off the same schedule. So they help them, organize the follow-ups, do a lot of the tedious, epic work time. And I think there's enough gain from there that there's enough to do some of these other activities. As long as we cast them correctly, I think it's worked out well and not have people more diffusely involved with the fellowship. I think by making it much more focused, all right, you're going to work with so-and-so on neuro, but nothing else. And I think that's worked out very well. The staff does get some extra time with it, but the way we have it here, we don't have financial incentives like that other study.
That's great. Thank you. I think I better call it because I think folks have to get to clinic and clinical work. But thank you, Carlos, Dr. Isada, so much for this Grand Rounds, which really, I think, it makes us all think more creatively. I like your spin on innovations versus interventions, and hopefully, I would love to think about how we could all collaborate in the future.
Thank you so much for all your time. I appreciate it.
All right, I'll see you later.